Good evening, ladies and gentlemen. A very warm welcome from the Chief Medical Officer of Syntellix, which is obviously me. And I'm very happy to have two such exciting topics tonight. And we also have experienced users of this innovative technology, MAGNEZIX, who are on first Thomas Bayer, who's an orthopedic and trauma surgeon from Ireland, and Özkan Köse, who is professor of orthopedic surgery in Turkey. We start now with two videos, have the discussion in the end, and I hope you have a wonderful session. So Thomas, the stage is yours.
Good evening, ladies and gentlemen, and thank you very much for asking me to give this talk today at your meeting. My name is Thomas Bayer, and I'm a consultant orthopedic surgeon based in Ireland. And I'm working in a Dublin hospital called the Beacon Hospital, as well as in Tullamore, which is most of you will know from the Tullamore Dew whiskey. And I'm the present secretary of the Irish Orthopedic Foot and Ankle Society, which is a pretty small society, not comparable with yours. So my topic is indications for magnesium-based implants called the MAGNEZIX. Company is called Syntellix. And I want to share my experience in using them, especially in trauma, foot and ankle cases. Those are the available implants. I'm using the 2mm screw, which has the same design as a Baroque screw, and then I'm using the cannulated 3.2mm screw and a 3.5mm screw, which is similar to a normal cortical screw. And then in terms of pins, I have the 2mm pins for refixation of acute osteochondral of the talus. I started using those MAGNEZIX screws back in November 2016, and I would have used 312 screws so far in 156 patients. And I mainly use them in elective and trauma foot and ankle cases. If you start with a new implant, you always have to ask yourself, why is there a need to change? Well, in my case, it was pretty aggressive in removing metal after fixation, especially in a young population because of the stress shielding. You can imagine if you have a sturdy implant, the bone beside it would not have the same biomechanical features. As Wolff's law says, healthy bone will remodel in response to a load, and the load would certainly not be the same if you have a sturdy implant in. So, and then it's very convenient in a pediatric population where you're almost obliged to remove the metal post-operatively. It has minimal artifacts post-operatively if you need CTs or MRI afterwards. And then there are cases where you might have to go back in after a couple of years and where you expect a post-traumatic arthritis, for example, and at least your hardware won't be in your way if it dissolves. And it has a pretty high patient acceptance if you tell them about the implants. The corrosion happens and you will get magnesium hydroxide and small amounts of hydrogen gas as it dissolves. And those are the cases, this is not a trauma case, but it's just to show you, to demonstrate on how I started to use them. So this is a case with a severe hallux valgus deformity where I fused the first MTBJ, I did a corrective fusion. And then initially I used those MAGNEZIX screw as a compression screw and put a plate on top of it and had pretty good results. So then I started to use an Aiken osteotomy, as there were enough publications already done around the group from Hanover. And the patients were very satisfied with the results, and I was, of course, as well. And as I had the screws available on the shelf, then I started using them in trauma cases. For example, in this 25-year-old boy with an avulsion fracture of his distal fibula. That's his MRI. I reattached this avulsion because I felt it's too big to be excised, so I refixed it with a small MAGNEZIX screw. You can't really see the MAGNEZIX screw on this X-ray, and that's why one of my scrub nurses initially called them the ghost screws, because even in the intraoperative images you see them if you know where they are, but they're hard to find. And then I reattached the ligament there with a small bone anchor. It's another case in a trimalleolar ankle fracture. Sometimes you have a small enough medial malleolar fractures, and in this case I use this subchondral 3.2 millimeter screw for refixation. But if you have a reasonable enough medial malleolar fracture, you could use the normal 3.5 millimeter screws. This is another case in a skateboarder, 32 years of age. And he fell off his skateboard and sustained this type 3 navicular fracture with highly comminuted and shortening of the medial column. In those cases, you have the option to do a primary fusion with a bone graft, but I decided to reconstruct the navicular and fix it with different little MAGNEZIX screws, but then still to protect my reconstruction. I would have had the option for an external fixator, but I decided to put a bridging plate in, which I removed after 6 months, and the patient is doing well, has a pain-free, functional, plantigrade foot. Of course, he's a little bit stiffer now in the midfoot, but I would say, given the type of injury, it's a pretty good result. And this is another gentleman. He's 44 years of age, construction worker, fell off a scaffold from a 2-story building and sustained this comminuted talar body fracture, which was initially open. So he was initially treated in another center, and they washed him out, and that large piece was put in the bin. And then he was referred to me. He had a provisional external fixator put on in the other hospital, but as there was substantial bone loss, I used a 3-cortical iliac crest bone graft. We attached it with different MAGNEZIX screws. That's the intraoperative imaging, where I provisionally held it with a couple of K-wires. Then I reconstructed his talar body with his bone graft and the fixation, and fixed it with different MAGNEZIX screws. My approach was through a medial malleolar osteotomy, which at that time I didn't have the 3.5 millimeter screw, so I just used the usual AO 3.5 millimeter screws for refixation. You can see pretty reasonable reconstruction of the talar body. But of course he's definitely stiff, but his pain on exertion is about 2 to 3 out of 10. So he would need the occasional paracetamol if he walks or stands for a longer time. There's another case with a typical T-low fracture. Then the MAGNEZIX screws for this type of injury are post-operative finding. You see the circle with a screw and with an anatomical reduction. Then, as I said, again, in a pediatric population, this implant is ideal. At the time, this was in 2017, I didn't have the 3.5 millimeter screw, but now I have them. So I would have used a 3.5 MAGNEZIX screw for the metaphysis. I'm using a combination for the epiphysis. I use a cannulated 3.2 screw, and under image intensifier you can check your position, and then you put the screw in. On the medial image you see the screw is already in with good compression of the fracture site. And then, as I said, nowadays I would use a 3.5 MAGNEZIX screw for the metaphysis as well. There's another few cases on the left hand side with fibular plate and 2 screws on the metaphysis and a small 3.2 millimeter screw on the epiphysis. And on the right hand side, this is another case. This is not the same case, but 3 months post-operatively, where you see kind of a small amount of transformation zone around the screws, but anatomical bony consolidation. And there's another few cases in 3-plane ankle fractures. You see, in those cases it was so I purely used MAGNEZIX screws, and they all did well, and we will publish our results soon. We published a case where we fixed olecranon fractures with a MAGNEZIX screw, and they all did functionally and radiologically well. But we also are just submitted last week our results in 3 plain ankle fracture in a pediatric population where we had a 1-year follow-up, and they all had excellent radiological and functional outcomes. There are many more indications, such as patella or olecranon. You can use them in different parts of the body, which is certainly not part of today's topic, but just to let you know, you could use it in other areas as well. And of course, there are always some issues or complications. So the first one is the so-called transformation zone I just told you, as you have degradation of the implant, and so you need to teach the whole team, and especially the radiologists. Otherwise, they would put into the report some loosening of the screw or even abscess formation or cyst formation. So you need to let them know that this is part of this implant. And then with this number of screws already used, I had 1 implant failure where you used a cannulated screw for a fixation of a medial malleolus, which was probably a little bit too weak for it. You have to know the strength of the MAGNEZIX screw is comparable with that of bone, and it's not as strong as steel, so you need to be clear enough with your indication. I had 1 deep wound infection in an open ankle trimalleolar fracture, but the wound was more on the lateral side and the screws were used on the medial side, so I couldn't really blame the implant for it, but I have to mention it. And then I have 2 wound instances where that did respond well to conservative management. So in conclusion, you have a biodegradable implant and it's good to excellent clinical results. It's ideal for foot and ankle surgery, especially for intra-articular fractures. It has a high patient satisfaction rate, and I haven't seen any adverse reactions so far. Removal of metal is not required. You have this before mentioned transformation zone, so you need to teach the whole team, and you need to consider well the strength of the implant. Thank you very much for your attention, and please don't hesitate to ask any questions. Thank you.
Okay, Thomas, thanks very much. And we have the next video from Özkan.
Dear Chairman and dear colleagues, good afternoon to everybody. My name is Özkan Köse. I'm from Turkey and working in Antalya Training and Research Hospital. In this presentation, I am going to talk about the indications and use of magnesium bioabsorbable screws in foot and ankle surgery. In our clinic, we are using magnesium screws since 2015, and we have operated more than 300 cases up to now during the last 6 years. In general, we prefer magnesium screws for fracture fixation and osteotomy fixation around the foot and ankle, and this is the most common indications in our practice. This is the list of most common indications in our practice, and now I'm going to show some case examples and their follow-up regarding these fractures. The first indication is medial malleolar fracture fixation. 2 parallel compression screws inserted perpendicular to the fracture plane is advocated as the optimal treatment for most transverse and oblique medial malleolar fractures, as you can see here. This is a 20-year-old patient with an isolated displaced medial malleolar fracture. This is the preoperative radiograph, and these, as you can see the fracture here, and these are the follow-up radiographs at 9 months and at 21 months. You can see the union of the fracture without loss of reduction, and the screws are seen as silhouette at the end of almost 2 years. This is another example of a medial malleolar fracture treated with 2 magnesium screws. You can see the fracture here. This is the postoperative radiograph, 2nd month and 15 month. Metallic implants often become symptomatic in the medial malleolus area, and the need for removal is frequent in this region because the soft tissue support is weak and there is an external pressure from the shoe wear. So fixation of these fractures with absorbable screws might be advantageous in medial malleolar area. We have observed gas in soft tissues and as well as in the bone. This is the chemical formula of the corrosion process. When the magnesium reacts with the water, it turns into magnesium hydroxide and the hydrogen gas is released. As you can see here, this is a magnesium tablet and the water. And here's an example of postoperative radiograph and the CT of a patient with osteotomy fixation. You can clearly see the gas within the soft tissues. However, this is a normal corrosion process and it doesn't cause any problems. Here is the gas formations and it doesn't cause any problems and complications. And most importantly, this gas formation does not interfere with the bone healing. The gas is also found in bone like this, particularly around the screws. However, this gas formation is gradually absorbed and disappeared with time. This is a typical case that shows the gradual disappearance of the gas around the screws. And as you can see, at the end of 2 years, there is no gas formation around the screws. And this is the CT appearance at 1.5 months, and at the end of first year, you can see the union of fracture and disappearance of gas around the screws clearly. The presence of screws and silhouettes in long-term radiographs may suggest that these screws are not totally absorbed, but it's not the case because we have performed volume rendered 3D CT in some of our patients. Yellow color is marked with materials higher than 1,500 Hounsfield unit in the CT. You can see the gradual disappearance of the high density and the yellow color around the screw. This clearly shows the gradual disappearance of the screws also. Another indication is talus osteochondral lesions. In fact, medial malleolar osteotomy fixation for talar osteochondral lesions. Here is a 24-year-old male patient with a cystic medial lesion. You can see here the CT and the MRI of the patient. I prefer to treat these large cystic lesions with autologous osteochondral grafting, in other words, mosaic-plasty. I take osteochondral grafts from the lateral femoral condyles and transfer these grafts, cylindrical grafts, to the talus using chevron medial malleolar osteotomy, as you can see in the slide. And I use either 2 or 3 magnesium screws for the fixation of the osteotomy. And I would like to show 2 cases. This is the first case, and I followed this case up to 20 months. And as you can see, the union of fracture, union of osteotomy is well established, and there is no problem with the union, and the screws are seen as silhouette here also. And this is the second case. You can see the 5th month, you can see some gas formation around the screw, but at the end of 30 months, 2.5 years, there's no problem with the fracture union, and the osteotomy is well united. Magnesium screws can also be used in pediatric trauma cases, such as tilo fractures, as seen in this case. This patient is a 15-year-old girl who admitted to the ED following a twisting ankle injury. And you can see the CT confirmed the tilo fracture. These are the long-term follow-up radiographs of this case. We have performed magnesium screw fixation. In this case, this is the 1st month, 4th month, 16th month, and the 44th month's follow-up of this patient. This is another case very rarely seen in adults called adult tilo fracture. Here is the fracture line. Since it's a large intraarticular fragment, we performed open reduction and fixation for this case. Here are the follow-up radiographs at 2 months and the 4th month. This patient had a displaced lateral malleolus fracture. It's an infrasyndesmotic Weber type A fracture. We performed an intramedullary screw fixation. for this patient. As you can see, at the first month, second month, third month, 1 and 18 month, and at the end of 2 years, serial radiographs. We have also published this case, and you can find this the full text in PubMed. This is another case with lateral malleolar fracture, with a Weber type A lateral malleolus fracture. Here is the fracture. We have also performed 2 intramedullary magnesium script for this fixation. You can see at the first month, you can see the gas formation around within the soft tissues. This is the second month, and at the end of 9 months, you can see the union of the fracture without any problem. This patient had an interarticular talar head fracture. We fixed it with 2 magnesium scripts, and here is the fracture line, and these are the postoperative radiographs, and you can see the magnesium scripts here. This is a 14-year-old boy who presented to our ED with a pedestrian traffic accident with Hawkins type 3 talar neck fracture associated with subtalar dislocation. And you can see the CT of the 3-dimensional CT. We performed open reduction and 2 convergent magnesium script fixation for this case. This is the second month, and this is the 5th month, and we are still going on following this patient. This is an interesting case, which is a rare combination of fractures. The patient had lateral talar process fracture, which is also called snowboard fracture, and substanticulum tari fracture of the calcaneus. The first fracture is here, and the second fracture is here, and you can see the CT imaging of this patient. Here are the fractures. We also fixed these patients. We performed mini incisions and percutaneous fixations, because magnesium scripts are cannulated scripts, and it provides an important advantage to perform minimally invasive surgery. Here are the screws. Finally, it is well established that magnesium screws are perfect fixation implants for chevron osteotomies in hallux valgus deformity correction. You can see some examples here. Several previous studies, including our research team, confirmed the efficacy of safety of this indication in this hallux valgus. Here are some papers we have published since 1918 in our clinic. We have published 5 papers about magnesium scripts in our clinic. As a conclusion, magnesium scripts are safe and effective in a variety of public indications in foot and ankle surgery. Gas formation within the bone is a normal corrosion process, and implant removal is totally abundant with magnesium scripts. Thank you for listening, and I can take your questions right now. Thank you very much.
All right, guys, thank you so much for your presentation, which were very nice. Thanks to Thomas and Özkan, and I heard from the chat from the audience that there are 2 questions to maybe the both of you. How often did you see resorption of bone and pseudarthrosis in your cases? One remark before you answer: we do not speak about resorption because it's not really sure whether this is resorption or not. Most of the papers indicate that it's not. We talk about radiolucent zones, and we have a colleague in Hamburg who was investigating those radiolucent zones, and he found that with the coating of a screw, he found a logarithmic reduction of those zones, and without coating, a linear correlation. But there was no correlation to clinical appearance. So what is your experience with those radiolucent zones? Özkan, you have, maybe you start because you have published a lot of papers where you describe them.
Thank you for the question. As I show in my presentation, this is gas formation in the bone is a normal corrosion process. So this is gradually absorbed, and you cannot find those gas formation in the late radiographs, and they don't even cause any bone healing problem. I didn't have any pseudoarthrosis or bone resorption in my cases. Maybe I'm choosing my indications very carefully. If the fragment is very, very small, in that case, that small fragments may be absorbed because the gas is releases within the bone, and if the fragment is too small, in that case, it may not be a good indication. Otherwise, you will not have any problem with these screws, and the gas formation is not a problem.
Maybe one of the questions which is combined with that phenomenon of radiolucent zones is also the fact that we sometimes see so-called broken screws, which might be a problem for titanium or steel implants. But I have seen now 2,000 cases at Syntellix. So I have my own opinion, but I don't want to share that before I ask Thomas. Do you see a breakage of screws, and what do you think? Do they interfere with bone healing or not?
I would say, well, this so-called, let's call it whatever you like, transformation zone and everything, I think we need, because we don't really know what's going on in this. But I must say, at the beginning, 5 years ago, when I started using them, that radiolucency or that transformation zone around the screw, you have to get used to it. But then I saw that the patients are doing clinically well. There was a question in, have you seen any non-unions in it? The answer is no. It's always difficult to say I have no complications, but the indication is pretty clear. So it's used in a hallux valgus, it's used in a pediatric population, it's used in trauma, and normally those are conditions where you have good bony healing. But I would be careful in naming it lucency or a problem, because it doesn't correlate to the clinical findings. And the most, in my own experience, this phenomenon at 3 months is the biggest. But if you re-X-ray them, then after 6 months, you see a reduction of it. And there might be even the case that there's an osteoconduction into where the screw disappears. So especially in small fragments, as you saw in my trimalleolar ankle fracture, with this subchondral thing at the 1 year X-ray, it was filled up with bone, and you can imagine where the screw is or has been, but that has been filled up with cancellous bone. So I think especially in small fragments, it's ideal. But as I said, you need to teach the whole team and the radiologists as well, because initially when I use them, of course, they will comment on it and give you all sort of, as I said, abscess formation or cystic lesion or everything. But you need to tell them that it's part of the degradation. And as the bone is healed by the time that the implant weakens, I haven't seen any screw breakage.
Okay, so we have only 1 minute left. Thanks for your answer. And there is eventually only one question or just a remark.
I would like to add something about...
We haven't got the time, sorry, Özkan. We're nearly at the end because we have to go to the next session. So I won't let the colleagues wait here, but maybe the last remark from the audience was that do not forget the basic fracture of the metatarsal 5. I just had that today because I saw a case. And I wonder if this is a good indication, because I saw in the meanwhile about 10 cases with Jones fractures, and they all healed very well. I was wondering myself, so last question to you, just one sentence. Have you got any experience with that?
Me?
Yeah.
No,
Jones fracture?
No, I didn't experience with Jones fracture.
And Thomas?
No, but it certainly would be a good indication, I would say, yes.
All right. Okay, I hope we are in time. I thank all the people attending this symposium. My special thanks goes to Thomas in Ireland and Özkan in Turkey. And I hope that you learned a bit about the innovative technology, and thanks very much to Germany.
Thank you.
Thank you.